Welcome back. Today, we're diving into the world of pediatric hernias. Now, if you work in pediatrics or if you're a caregiver, you know firsthand that this can be a pretty scary diagnosis to hear. But our goal today is to flip that script. We're going to take that fear and turn it into clear, actionable confidence. We'll be breaking down the exact pathophysiology, the sneaky warning signs, and the full recovery process, so you walk away with a complete picture of what's going on and exactly how to handle it. To really understand what we're dealing with, we have to look at the anatomy. Fundamentally, a hernia is just a protrusion of an organ, or sometimes multiple organs, through an abnormal opening. Think of it like a gate in a fence that was accidentally left open, and now the dog is slipping out. From a developmental standpoint, these little weak spots happen in pediatric patients because certain crucial developmental milestones just didn't finish closing up before the baby was born. The abdominal wall is super complex, and as all those tissues fuse together during gestation, tiny gaps can get left behind. Now, on its own, a simple hernia might just be an anatomical quirk, no big deal. But things take a serious turn when that protrusion gets constricted. If the surrounding muscle clamps down and cuts off circulation, we suddenly have a rapidly escalating medical crisis on our hands. Here is a quick roadmap for our explainer today. We're going to define what a hernia is, look at the three main types, talk about spotting the signs, dive into complications, surgical fixes, and then wrap things up with post-op and fluid care.
All right, let's jump straight into section 2, the three main types of hernias you're going to encounter.
There is a real night and day difference between our first two types, umbilical and inguinal hernias. Umbilical hernias happen when the umbilical ring doesn't fuse completely. We see this all the time, especially in preterm infants, simply because the core muscles haven't fully tightened up yet. But the cool part? They usually fix themselves. By the time the kid is 3 to 5 years old, the core strengthens and the gap closes. Inguinal hernias, on the other hand, are a totally different beast. These are caused by the persistence of the processus vaginalis. Basically, during fetal development, there's this little membrane pouch that drops down to let the testicles descend, or the round ligament in girls. It's supposed to completely seal shut before birth. When it doesn't, you're left with an open tunnel right into the groin. And unlike umbilical hernias, inguinal hernias do not magically heal on their own. They require prompt elective surgical repair so loops of bowel don't accidentally slide down that open tunnel. 80%, that is a massive chunk. It represents the percentage of all childhood hernias that are inguinal. So the vast majority of the time, this is what you're dealing with. And if we look closer at the demographics, boys are affected about 6 times more often than girls. This huge male predominance is directly tied to that complex developmental journey of the testicles traveling down the inguinal canal. It just leaves so many more chances for that processus vaginalis to stay open. And that brings us to the outliers, femoral hernias. These are extremely rare in kids, literally less than a 1% incidence rate. But even though they're rare, we absolutely have to keep them on our radar. Why? Because they present with severe abdominal pain and cramping, and the swelling is noticeably lower down in the groin. Interestingly enough, you'll actually see femoral hernias more in girls than in boys, and they carry a remarkably high rate of incarceration, meaning the bowel gets trapped very easily, and that requires immediate intervention.
So, moving right along to section 3, how do we actually go about spotting the signs?
For our most common culprit, the inguinal hernia, the presentation is pretty classic. You'll usually spot a painless bulge or swelling in the groin area, but it can be sneaky. It often vanishes entirely when the baby's resting, only to pop right back out when they bear down, like when they're crying or coughing. Now, for clinicians, there's a brilliant diagnostic trick called the silk glove sign. Even if the bulge isn't currently poking out, a provider can gently roll the spermatic cord structures under their finger. If that unclosed processus vaginalis is hiding in there, it literally feels exactly like rubbing 2 layers of smooth silk together. It's a highly specific tactile clue that confirms the defect is there. Okay, let's step into the danger zone. Section 4, complications and when to really worry. It's the million-dollar question for every caregiver and nurse. How do you know when that harmless little bulge has suddenly turned into a life-threatening medical emergency? Let's trace how this cascades from bad to worse. A partial obstruction might just look like a cranky baby. General irritability, maybe some groin tenderness, and a slightly bloated belly. But if that herniated loop of bowel gets completely trapped outside the abdominal wall, we call that incarceration. You can't push the sac back in. If it sits there untreated but pressure ramps up, leading to strangulation, this is your red alert emergency. Strangulation means the arterial blood supply is choked off entirely. Within hours, you're looking at ischemic injury and dead necrotic bowel tissue. The child's symptoms will explode. They'll start vomiting profusely because their GI tract is totally blocked, and they won't be able to poop or pass any gas. At this stage, the clock is aggressively ticking.
Right, so how do we fix this? Let's get into section 5, surgical fixes and treatments. The treatment plan here completely depends on the current state of the hernia. We basically have two distinct pathways. For a standard reducible inguinal hernia, the gold standard is prompt elective repair. It's an outpatient procedure for a healthy kid, usually scheduled as soon as it's diagnosed, so we can get ahead of it. But if we're dealing with an incarcerated or strangulated hernia, we drop everything. That is an immediate rush to the operating room to release that muscle, get the blood flowing again, and repair the defect before permanent bowel necrosis sets in.
But what if you're managing a non-emergency hernia and surgery is still a few days out? We've got to educate parents on 3 vital at-home steps to safely reduce the hernia if it decides to pop out. Step 1. Draw a warm bath. The warm water helps relax those tight abdominal muscles. Step 2. Avoid holding the baby upright, because gravity just pushes more pressure down onto the defect. And Step 3. Do whatever it takes to soothe the child and stop the crying. Now, we completely get it. Telling a stressed parent to keep a baby from crying sounds literally impossible. But that's exactly why those physical steps, the bath and the flat positioning, are so crucial. They passively reduce the pressure and keep the kids safe until surgery day. Finally, let's wrap up with section 6, post-op and fluid care. After surgery, if a child came in with a bowel obstruction and was vomiting severely beforehand, they are going to be incredibly depleted. Trying to rehydrate them orally just isn't going to cut it. They will absolutely need hospital IV fluids to replace all that lost volume and stabilize their electrolytes. We're talking isotonic crystalloids here, like normal saline or lactated ringers. As a clinician, you'll be on high alert for physical signs of severe dehydration. You're checking for noticeably sunken fontanelles on the baby's head, no tears when they cry, and dangerously poor skin turgor. Post-op fluid management requires absolute precision. First, check any vomit for bile or red coloring, which signals deeper GI bleeding or a continued obstruction. Second, track those wet diapers obsessively. A great clinical target is checking urine-specific gravity to make sure it drops well below 1.020, proving they're getting hydrated. Third, and this is huge, do not let those IV fluid shifts happen too fast. Pumping fluids too quickly into a tiny dehydrated body can trigger severe sodium imbalances, leading straight to cellular edema and water intoxication. And lastly, a genius little trick for measuring belly edema: lay the baby flat and literally draw a mark with a pen right over the umbilicus. It guarantees that every single nurse on the next shift is measuring fluid retention from the exact same starting line. Through all of this intensive clinical care, we cannot forget the human element. For a parent, seeing a bulge popping out of their newborn's belly button is terrifying. Half our job is just providing solid reassurance. We have to kindly educate them that umbilical hernias usually heal perfectly on their own. And, importantly, we need to bust those old wives' tales, like stropping a coin tightly over the belly button to flatten it out. It absolutely doesn't work, and all it does is cause painful skin breakdown on a very vulnerable baby. So, we've walked through the pathophysiology, the sneaky warning signs, and the critical surgical pathways, but I want to leave you with this scenario. Picture a persistent, crying infant rolling in with a hardened groin bulge and active vomiting. Are you prepared to recognize that emergency before the bowel tissue starts dying? Spotting the fine line between a harmless anatomical quirk and a strangulated, life-threatening crisis is a skill that literally saves lives. Trust your assessments, look for those key signs, and you'll be perfectly prepared for whatever walks through those doors.